Textbooks of Rockwoods and Green's Fractures in Adults. Section 1. General Principles. The Epidemiology of Fractures and Dislocations. Fracture prevalence. Fractures were related to motor vehicles in 1894 to 1903 with relatively no motor vehicles. Fractures likely resulted from workplace, scapula, tibia, fibula, ankle fracture. Decreased prevalence of hand fractures nowadays may result from safer work environment. This table shows the epidemiology of fractures is changing and there is no doubt that it will continue to change. Fractures in males. This table shows that in males the average age is 42.4 years and only 17.1% of fractures occurred in male older than 65 years of age. Fractures of metacarpus, finger phalanx, distal radius, ulna, and ankles comprise 52.1% of all male fractures. Fractures in females. This table shows that in females the average age is 61.8 years and 48.8% of fractures occurred in patients older than 65 years of age. The obvious tendency of fragility fractures to be much more common in females is highlighted in this table. Gender and age. Pu and Cook highlighted that men have a bimodal distribution of fractures, while women have unimodal distribution. Incidence is significantly increased postmenopausal years. Young males are associated with high-energy fractures, while elderly related to osteoporosis. 94.3% fractures in older females related to falls from standing heights. Social deprivation. Another factor related to incidence of fractures is social deprivation. Social deprivation correlates with musculoskeletal pain, high-energy lower limb trauma, Perthes disease, an outcome after hip arthroplasty, and others are fracture in children, adolescents, and young adult males. Fractures related to social desires. This table shows the incidence of fractures when deprivation is taken into account. Once the figures are adjusted for age, it can be seen that in males the overall incidence of fractures in the very socially deprived is about 4 times that of the rest of the population. And in females, the equivalent figure is about 3.5. Open fractures. In adult males, the highest incidence occurs between 15 and 19 years with linear decline afterwards. In young males due to high-energy injuries, while in females there is a unimodal distribution with rapid increase. In elderly due to increased virility and osteoporosis. Severity of open fractures. This table shows that open lower limb fractures tend to be more severe than open upper limb fractures. Open fractures of the femoral diaphysis, distal femur, patella, proximal tibia, tibial diaphysis, distal tibia, talus, and calcaneus tend to be associated with the highest ISS and MSI and the highest prevalence of Custulo III fractures. The majority of these fractures were caused by high-energy injuries such as motor vehicle accidents or fall from height. The highest prevalence of Custulo type 3 fractures is seen in fractures of the hindfoot and midfoot. Multiple fractures. Although most fractures present as isolated injuries, there are accepted patterns of fractures. For examples, between calcaneal and spinal fractures in a fall from height, and the second one proximal femoral fractures and distal radial or proximal humeral in elderly patients after fall from standing heights. Multiple fractures are usually due to high-energy injuries and increasing aging. Fragility fractures. Fragility fractures are due to osteoporotic fractures. Osteoporotic fractures are fractures occurring at sites associated with low bone mineral density after the age of 50 years. This is the list of mode of injury: falls from standing height, falls from a low height, direct blows, assaults or cross injuries, sports, motor vehicle accidents, cyclists, motorcyclists, pedestrians, vehicles drivers, vehicle passengers, pathologic fractures, stress and spontaneous fractures, and gunshot injuries. Motor vehicle accidents are often perceived to cause the majority of fractures, but in this table, it shows that this is not the case. In 2000, 7.2% of all fractures in Edinburgh occurred as a result of motor vehicle accident, but it is now 5.2%. And there is a little doubt that the decline in motor vehicle accident fractures is partially responsible for the lower incidence of fractures, such as those of the tibial diaphysis. Specific fracture types. Clavicle. This table shows that fractures of the middle third of the clavicle are rare, and it should be remembered that in younger patients, this fracture may involve the proximal physis. It shows that standing falls, sport, and motor vehicle accidents are the commonest causes of clavicular fractures. Scapula. Scapular fractures are divided into fractures of the body and neck, glenoid, acromion, and coracoid. The epidemiology of these fractures is shown in this table. Proximal humeral. This table shows the epidemiology of proximal humeral fractures. They have been divided according to the OTA classification into unifocal extraarticular, bifocal extraarticular, and intraarticular fractures. About 2/3 of proximal humeral fractures are unifocal extraarticular fractures, and only about 8% are intraarticular fractures. Humeral diaphysis. This table separates the humeral diaphyseal fractures according to their location within the humerus or whether the fracture was periprosthetic or not. Distal humeral. This table shows that the majority of distal humeral fractures are actually OTA type A extraarticular fractures, with only 14.6% of the fractures being type C intraarticular fractures. Proximal radial and ulnar. This table shows that the patients with proximal ulnar fractures had the highest average age of all patients who presented with proximal forearm fractures. Radius and ulnar diaphysis. The table shows a similar prevalence for isolated ulnar and radial diaphyseal fractures. It also shows that the patient's average age and gender ratio was similar in these three types of forearm fracture. Distal radial and ulnar. The table shows that the majority of distal forearm fractures are distal radial fractures, with only 1.7% of being isolated distal ulnar fractures. Both have a type A distribution, but more males present with distal ulnar fractures and the average age is less. Carpus. The table shows that overall about 60% of all carpal fractures follow a standing fall, with most of the remaining fractures being caused by a sporting injury or direct blow. Metacarpus. The table shows that metacarpal fractures are least common in the thumb metacarpal and become commoner as one moves toward the ulnar border of the hand, such that 17% of metacarpal fractures occur in the ring finger metacarpal and 60% in the little finger metacarpal. The average age is highest in patients who present with thumb metacarpal fractures, and more females present with fractures of the ring and little finger metacarpals. Finger phalanx. The table shows an analysis of the epidemiology of fracture in the different fingers and as with the metacarpal fractures. It is apparent that the little and ring fingers are the most affected. The average age and gender ratio of the patients who present with fractures in the different fingers is not dissimilar and all have a type B distribution. Proximal femur. The table shows that in the study year, the majority of proximal femoral fractures were subcapital intracapsular fractures. The average age for subcapital and intertrochanteric fractures was similar, although the average age of for patients with greater trochanteric fractures was lower and there were more males. Femoral diaphysis. The table shows that femoral diaphyseal fractures have been divided according to whether they are subtrochanteric, diaphyseal, or periprosthetic. It shows that 69.5% of patients sustain their fractures in a standing fall, but if one simply looks at the subtrochanteric fractures, 76% were injured in a standing fall with a further 12% having a pathologic fracture. Distal femur. The table shows that in 2010 to 2011, 27.8% were periprosthetic fractures. Patella. The table shows that about 3/4 result from a standing fall. There is a small male cohort in which patella fractures caused by motor vehicle accidents. Proximal tibia. The table shows that while standing falls in older patients were the commonest cause of proximal tibial fractures, about a quarter were caused by sports injuries and occurred in younger adults. A variety of sports were involved, but 33.3% of the fractures were caused by soccer. Fibula. The table shows that a fall from a standing height will cause fibular fractures in older females, and 68.4% of the fractures caused by falls were in the fibular neck. This is very different from the sports-related fractures, where 77.8% were fibular diaphyseal fractures, which were probably caused by direct blows. All of the fibular fractures caused by motor vehicles accidents were located in the proximal fibula, and 60% occurred in cyclists or motorcyclists. There were no open fractures and few multiple fractures, although those that did occur were in the lower limb. Distal tibia. The table indicates that the OTA type B partial articular fracture tends to occur in younger patients, with the OTA type A extra-articular fracture occurring in older patients. It also shows that when present, multiple fractures are commonly seen in the hand, foot, and contralateral ankle. Ankle. The table shows that the ankle fractures divided according to the OTA classification. It shows that type B transendesmotic fractures accounted for about 2/3 of all ankle fractures, and that about 80% of all fractures occur as a result of standing fall, although many of these fractures may well have occurred as a result of the twisting injury. Talus. Talar fractures were the least common fractures seen in the study year, accounting for only 0.2% of the fractures. The talar fractures have been divided according to the OTA classification. The avulsion fractures, the process fractures, and head fractures have been combined together, and the neck and body fractures have been recorded separately. Calcaneus. In this table, calcaneal fractures have been divided into extra-articular tuberosity fractures, extra-articular body fractures, and intra-articular fractures, the latter being a fracture which has received considerable attention in the orthopedic literature in recent years. Midfoot. The table shows that the cuboid bone had the highest prevalence of fractures, and females were more commonly affected, with males presenting with more fractures of the cuneiforms and navicular. Metatarsal. The table shows that the fractures of the hallux metatarsal were least commonly seen, and only 17.6% of them were caused by a standing fall. Metatarsal fractures become more common as one moves toward the lateral border of the foot, and 69% of all metatarsal fractures affect the fifth metatarsal. Pelvis and acetabulum. The table shows that in the study year, about 86% of pelvic and acetabular fractures involve the pelvis, and 14% the acetabulum. The average age of patients with acetabular fractures was slightly lower, and the gender ratio of the two fracture types were markedly different. Spinal. The table shows an analysis of the spinal fractures that were admitted during the study year. Most were thoracolumbar and were caused by a fall from height or a standing fall. The majority were seen in males, but as has already been stated, many elderly females sustain thoracolumbar fragility fractures but do not seek medical help. Epidemiology of dislocation. The table shows the numbers, prevalence, incidence, average age, and gender ratio for all dislocations in the population. The distribution curve for all dislocation is also shown, as is the percentage of patients older than 65 years and older than 80 years. It should be noted that because dislocations of prosthetic hips are so common, they have been included in the analysis. Thank you.